First, we're going to start with Veenu Aulakh, who is an independent healthcare consultant, and she is president of, former president, excuse me, of the Center for Care Innovations. She's going to focus on the world of safety net care, Medicaid, and the intersections with technology. So without further ado, let me turn to Veenu Aulakh for a presentation.
Great, thank you, Sarah, and very happy to be here today to have this discussion and following up on Dr. Seshmani's comments. So if you could go to the next slide, I thought I would start by giving you a little bit of context from where I'm coming from and where my comments will be. So my story at that intersection of technology, innovation, and health equity is I have worked both within health systems, really implementing technology and change, working at Kaiser and also within the safety net. Also bringing that perspective, working at a foundation, both as a person really at that intersection across the variety of stakeholders, including policymakers and plans, but also helping to start up an investment fund at the foundation where we were investing in startups. And also having worked at startups. And then over the last 10 years, I was leading an organization called the Center for Care Innovations, where we focused on implementing innovation technology within federally qualified health centers and public hospitals to really support patients and communities who are facing some of the large inequities in health and healthcare. And through that lens, if you want to go to the next slide, please. I think from those different viewpoints, I see a huge potential to advance health equity through technology. With a big but, I think there's some really important considerations that I wanted to talk about today. One is we know that marginalized and minoritized populations face some of the highest burdens of illness. But that also means there's the most to potentially gain through technology. But in order to make sure that they are gained, we have to ensure that we don't increase disparities and at risk of doing that if we don't implement it well and in a thoughtful way. I think there's many challenges that we've seen. There's still low uptake of technology. There's issues around access, whether it's the technology itself, the devices, broadband, usability, which I'm going to talk more about, and I think as well as trust and making sure that these solutions do meet people's needs. And I think the important thing, especially as I worked first at Kaiser and then working in the safety net, I think one of the big things I've realized is that there often is a need for additional support for certain populations. A lot of assumptions don't necessarily translate, and how do we provide that option for a little additional hand holding? And I think historically, I think the other thing that I've seen from the investment side, that there hasn't historically been a lot of investment and energy placed on developing solutions for some of the low income marginalized communities. But I feel like over the last few years in particular, there's been a big shift. As Medicaid market has been expanding and people are seeing opportunities in Medicaid, I think more and more investors and health plans are seeing this as an opportunity where there are some unmet needs, and recognizing that there's a strong case to be made to design and develop solutions to advance health equity. So we're starting to see more investors putting money into Medicaid companies like CityBlock and Waymark, Galileo. There's a lot more energy on behavioral health tech companies. And I think starting to see solutions to address some of those biggest challenges. The next slide, please. I also think what has also changed over the last 10 years that I think has also been exciting is the technology has evolved, both in the hands of patients. I think when I first started this work, it's hard to imagine, but we didn't have, cell phones weren't as prevalent. And now 97% of people have cell phones, 85% of people at all income levels have smartphones, according to the Pew Internet Group. And that's a major change. All of a sudden, you have that technology in people's hands to be able to engage in a very different way. And on the flip side, safety net providers and health systems, so the federally qualified health systems and systems that care for disadvantaged communities, also have electronic medical records. And that allows for incredible innovation and use of data, starting to see where those inequities really exist within communities, starting to figure out how you integrate data in more meaningful ways. And I think these two trends, and finally getting to that point where we have those solutions that we can actually work to develop solutions that work in the context of diverse end users. I think the one thing, and I think Dr. Seshmani talked about this as well, is, however, I think we still have a lot of work to do to make sure that the solutions are designed in a simple way, and that they're designed and co-designed with the populations we're trying to serve, which take into account language, literacy, the complex lives of patients. And I think starting to move from designing solutions for higher income communities and really thinking about how do you make sure that we're really designing with people is essential. And I think on the provider side as well, making sure that the solutions aren't out of reach for the safety net providers, that they're at the right price point, that they're taking into consideration what it needs to integrate effectively. So I think those are some of the considerations. While I think there's a lot of positive energy and moving in the right direction, how do we take some of those cautions in mind? And then the next slide. I also think one of the big challenges we continue to see is for many years, the policy and payment environment has been a major barrier for the adoption of innovations and some of these technology innovations in particular. It was hard to adopt the technologies when the payment didn't allow for it within a fee-for-service environment, which is most common still within federally qualified health centers and public hospitals. It's hard to pay for these digital solutions, and putting it on low-income consumers is obviously not the right. It adds an additional barrier as well. However, I think what's been exciting over the last 2 years during COVID, we saw what was possible if we lifted and adapted those policies. And I think telehealth provided that opportunity. So if you could go to the next slide, please. So the last couple of years, as I was transitioning out of the Center for Care Innovations, I was involved in a study that was sponsored by the California Healthcare Foundation and implementation with 23 health centers across California. And what we saw for over 20 years, I've been working in advancing telehealth, and what we were able to do, like within a month, was just phenomenal. We were able to pivot so quickly. We were able to demonstrate impact, and a lot of it obviously was out of need and a need to deliver care differently. But I think the reimbursement and legislation environment made a huge difference, both for providers being able to do it, and also we learned that patients were accepting of this. I think there was a lot of assumptions that patients in the safety net weren't able to use the technologies, they weren't interested, and I think we saw that wasn't true. And just two quick data slides. So the next slide. What we did see, and this slide shows over those 23 health centers and hospitals, what's changed. And the dark blue represents, you can see during when COVID first hit, we went from, the majority of care being done in the clinic to a high percentage being done virtually, with a big proportion of it being phone. At the highest point, 61% of care was being delivered virtually in primary care setting. And then if you go to the next slide, and I think what was most exciting, and this came up in Dr. Seshmani's points as well, for behavioral health, this is even more significant. It was it showed that with these serious access issues and a realization that care could be effectively delivered through virtual care. And what I think is most exciting is that it's even as we're coming out of the pandemic, it's sticking. People and the percentage of visits by video has increased and is staying steady. So, you know, I think that shift has been really impactful in seeing what is possible. I think the other thing that is the caution, the excitement, knowing that audio is an important option for these patients, but also the caution that we want to make sure that we don't worsen health disparities by shifting only to audio and having both options available. So I think the verdict's still out in terms of when is it most viable for video versus audio, but knowing that those access points have really changed and that we need to keep working on video as a viable option. So the next slide, so as we think to the future, I think there's some incredible opportunities again, where technology and innovation can really be impactful in addressing health equity and address some of the major challenges in the communities. One, I think virtual care broadly, we have seen what is possible. We've seen how it's impacted people's lives, being able to access care from their homes, especially in rural communities, not having to make, you know, those long drives, the convenience of people who are working and being able to take visits without having to transport into the clinic. I think there's some amazing stories that we've just been hearing from patients about how that has changed. And I think there's more work to be done to do that. Alongside that, I think we're still early in the safety net settings and thinking about how remote patient monitoring could be very impactful, especially for people living with chronic disease. And how do we, one of the points that Dr. Seshmani raised, how do we do more care at home? And how do we help rethink what some of those models could be? And I think behavioral health, I think we've seen the potential, and there's so much more potential given the incredible access problems that we continue to have. So I think some really exciting opportunities here. And then I think on the last slide, just wanted to mention, I think our considerations for the future is one, you know, we're still haven't finalized where we are around telehealth. There's in California specifically, the department has made some very the proposed policies are very positive for telehealth payment and legislation, and we're optimistic. But obviously, what's going to happen beyond the end of the year, I think we're hopeful that we are able to hold on to those changes because it's made such an impact in access. I think both on payment and in terms of legislation. I also think one of the important considerations is really being thoughtful about how we support patients with digital barriers and not it being an afterthought, but realizing that we need those options to make sure that we don't increase disparities and we do take in consideration some of the challenges that people may have. And I think most importantly is I think we really need to continue to involve marginalized patients, minoritized patients in the design and development of solutions and technologies. I think for too long, they haven't been included, and that's resulted in products that don't necessarily work for everyone. And then I think lastly, hopefully this trend in continuing to invest in solutions for Medicaid and in continuing to invest in that innovation so that we have solutions that work for everyone. So with that, I will pass it back to Sarah.
Great. Thank you so much, Veenu. And if you could just stay and leave this slide up, because I thought this was, thank you for your presentation. I thought your slide was really terrific. And, you know, this brings to mind so many follow-up questions. I know we could probably spend the whole hour. We want to get to Kara James's presentation. But I'm really curious, as you're looking at these considerations for the future, you know, one question came to mind. You know, you mentioned obviously the whole audio only versus video is a big debate happening right now. I'm curious, as you're looking at payment trends like across different payers, are you concerned that either, that there's going to be a trend towards a wide differential in payment for audio versus video, or like that payers are going to, somehow kind of have preferential treatment for telehealth and like create sort of disparities that way? I'm just kind of curious how you're seeing the payment shape up, or if it's too early to tell.
I mean, I think some of the recent proposed policy is recognizing that audio is a really important option, especially when you look at some of those graphs and think about where we are with virtual care. If we took away audio, I think we would cut off access for some of the most vulnerable populations. And I also think there's still, a lot of debate about, are they equivalent in terms of quality? And we don't have great data yet. I mean, I think we're starting to learn more about that. I do think in some of the proposed policies in California, they're really encouraging people, encouraging strongly that if audio is an option, you need to also make sure video is an option. So giving that flexibility to some of the patients as well. So I'm hopeful that audio, the payment parity is going to stay there, but I do think, I think there is a caution, and I worry that if we don't encourage video as being an important way to deliver care, we may end up creating a two-tiered system. So I think it's just a caution, but it's early to know in terms of quality what makes the biggest difference.